And the microbiome has been really interesting in the last couple of years, and how that shift and how the shift that everybody's undergoing through might explain some of the new things that we're seeing. Here's something we have decided not to do over Katie's dead body. The last agreement from the, well, is this just going on its own? I guess it is. This is something that is controversial, I think. And I think the pediatric panel that put this out is now beginning to look at it again and to say, wait a minute. Allergists have been doing skin testing for food and for other things since allergy existed. But the concern was that there might be irritants or non-associated issues that occur in skin testing that would put children at risk for vitamin deficiencies, for poor growth, and for deficiencies in calcium, vitamin A, B, D, folic iron, zinc, and iron. So what's happening now, I think, after that big blast statement, is that people are beginning to look at it a little bit different and say, wait a minute, let's tune this up a little bit. So before you stop doing any skin testing and atopic dermatitis, hang on, this is a pendulum, it'll swing back and forth, and I think it's going to swing back here. So step therapy is indicated in atopic dermatitis. You always know the first step is the skin emollient therapy and maybe antihistamines. I've never found them that effective in atopic dermatitis. Singular Bill Storm suggested that we add in that. Topical steroids, PDE4 inhibitors, the topical calcineurin inhibitors, which is still very difficult to get authorization for. That's one of the funny political things that happened through the years when these topical calcineurin inhibitors were developed, and they were so safe. And they started advertising to children even, and cartoon figures about super safe. FDA said, don't do that. And the companies basically said, hey, it's America, can do what we want to do. They rapidly found themselves in a black box situation, and black boxes to pediatricians mean something. Now, black boxes and other things don't necessarily mean it, but this one really stuck. And even though the Academy of Pediatrics and everybody concerned with dermatitis wants it changed, FDA has been pretty difficult about taking some of the warnings off of these, and therefore it's been very difficult to get some of the things that we would really like to have on the market again, or on the market where we could use them again. Now, here's a little practice pearl. I know you may know something about it, but let's say we got a person here with eczema, and let's say that it's the usual thing, which is flexor pulse and below and beyond. The idea of using wet wraps has kind of left us in the last few years. We got to start thinking about the way we used to treat things before we had all these there. And so people that are older like me can remember when we had nothing to treat this with except that, we walked up a hill in the snow and treated these things with emollients. But what a common, easy thing to do, I do use is wet wraps. I'll take a pair of socks from an individual and socks. White will come in, we'll cut some loops out of that, like a sweatband, soak them, and put them over these areas. And we do that 2 or 3 times a day, before school, after school sometimes, before bedtime. It works. The problem with eczema is not enough water in the skin, so one of the ways is to put water back. But it's a hard thing to do sometimes. We used to use things called zoot suits, where it was like a reverse scuba suit. And at the last hope, we'd hospitalize children and put them in wet wraps in the hospital. You never hear about that anymore, but those were things that we did before the day. So the step therapy at the last step has to do with biologics, with immunosuppressants, cytosporins, PUV, and all the materials that are now commonly available to us that were just witchcraft a few years ago. So here's one way. Dr. Weibel's going to talk about an easier way to do the grading of the disease. This is called SCORAD. And SCORAD basically takes each one of the, first of all, they look and see what's the surface area involved. And then they ask for an intensity score, and they do it with erythema, edema, oozing, excoriations up on the B section now, pigmentation, and xerosis, and give them a score, 1 to 3, total score. Then a subjective score, which is box C, and that's pruritus over the last 3 days on a scale of 1 to 10, and sleep loss for the last 3 days for skin. And the SCORAD formula, which looks daunting but actually turns out pretty easy to manipulate, in this case would be surface area 50%, intensity 12, subjective 12. There's the formula, and there's the answer. And when you look at eczema, mild, moderate, and severe, it's pretty easy to see that somebody that's got intense itching, is losing sleep, is going to be a graded individual that would meet the criteria for more aggressive therapy. Now, the problem is with any of these scoring areas, they're only a couple of days. We're dealing with chronic disease, and we're cutting out a section of 3 days in order to qualify for some pretty significant medications. And this is insurance issue. There are medical directors. Used to be you'd have a medical director that was a retired proctologist or something, and you could talk them on almost anything. But now they're getting pretty tough, and they want specific lines. And when I take over Blue Cross Blue Shield's Biologic thing in the next couple of months, it's my next career, then I'll change all this. We'll see. So interleukins are the first thing. What is an interleukin? Well, that's what it looks like. That's kind of difficult to grasp, right? I mean, it's a mass of proteins. They're a group of cytokines, secreted proteins, signals that are expressed and secreted by white blood cells, as well as some other blood cells. The human gene encodes more than 50 of these. We know a lot about probably half of them, but the term interleukin was accepted from inter as a means of communications, leukin, deriving from the fact that many of these proteins are produced by lymphocytes and actin leukocytes. Okay, now if they say that 14 times in a row, you'll pick it up. What is an interleukin? Basically, interleukins are just messengers. They're telling the immune system what's wrong, what to do. There are very few states where there have been an absence of leukotrienes analyzed. I mean, there are plenty of hyper immune systems, but not many low ones. So I've chosen to simplify this as I usually do and say that interleukin-4 and interleukin-13 are the ones that we're going to be looking at today. And these are nasty guys that we try to stop or that we think about. So next time you think about an interleukin, you can think about those old concepts. And there are lots more here that are running around in the background that we don't even know about. Interleukin 97, there's only been 50, maybe just 3,000 of them. We'll learn, by the way. But interleukins in atopic dermatitis are considered to be an issue because they're high. So you can measure interleukin 4, 13, 17, 22, 31, 33. Right now, and there are probably 15 more that are in various stages. You'll find them high. In atopic dermatitis, you'll find increased inflammation, and that contributed to barrier dysfunction and, of course, to itch. So the goal was to try to produce something that would inhibit the action of these materials. And it's not really very difficult. In fact, you can go on the internet today and buy interleukins. Harvey, you're the big one about immunizing yourself to, animal products and things. Here, buy you some interleukins, They're for sale. They come in all varieties. It's already been worked out. Now, getting a drug out of that's another story. Of course, you don't have to worry about those kind of IRB things, so you can go ahead and inject yourself with stuff. Okay. I should laugh. I mean, we do stuff to ourselves all the time that are crazy. I mean, when we were trying to find the mechanism of Xolair anaphylactic reactions, I froze it, injected it in myself, microwaved it, left it out, mixed it wrong, mixed it right. I could not produce a positive reaction on myself. So I never was able to say, as an incipient. So I kid you, Harvey, but I've done it too. And I also have in the back of my car, I have, yeah, I know. I figure it would feel vindication, I also have a box in my car with old EpiPens. They date back as long as 12 years ago. And they're in the car, they freeze, they boil, and it's a big summer activity. It used to be in my clinic, where we take the oldest EpiPen out and jab Dr. Lanier. And so its pulse rate was, okay, that one's still good, And we always thought it was a big issue, the short dates on EpiPens. Okay, so here we are trying to find some way to stop these primary immune issues. Now, there are plenty of other important interleukins than just 13 and 4, but these are the ones that have been kind of centered on in the last couple of years. How do you stop them? Well, there's been some revolutionary biologics that have resulted from the studies. And I think for atopic dermatitis, you look at, and I'm going to try to do the names. I sometimes get them and sometimes don't, but dupilumab I can get. Latuzumab, I got that one. Tricolumab, missed that one. Okay. So if we're just doing, since we're doing this verbally, we don't have to worry too much about, writing them down. So you guys, you can take my lead here. So dupilumab is the IL-4, IL-13. The latuzumab is anti-IL-13. And the one that's on the market now is Aubrey, which is IL-13. So all of them got advantages and disadvantages. And what we're going to do is to look at how these things work. What do they do? How long can you have them on? What are the dangers, risks, benefits? This is just an absolute miracle of anti-IL-4 and anti-13. This was in the British Journal of Dermatology. And it just shows what 8 weeks of, or 16 weeks now, of therapy can do for people who have had this mess all their lives. Now, I missed the introduction slide that I had because I had a kid on there that I'd been following since he was 2 months of age, and he's now in his 30s, and we had just died with him and his mother for so many years. The advent of this was just startling. I'd never seen anything like it. It was just a blockbuster. In fact, it was so good that it just revolutionized our thinking. So you've all seen the studies of IgA, EASI, BSA, sleep, POEM. Those are all measuring scales, and they just drop like a rock. So these are the kind of things that we really are used to seeing. I used to have children, women that would learn how to use steroids. They'd save them till they were going to graduate or had their photographs taken or if they were getting married. They knew they were going to get a flare, but they learned skillfully to use them. And this drug has just taken that away. I've had people with hand eczema, guitarists that needed their hands to be saved. So I'm just a big rooter for this particular medication. It is odd, though, that you see this, especially in depictions, you see that it increases eosinophilia. Don't let that bug you. There's nothing ever been shown to say that that's a bad thing, but you will notice as you follow up, if you do blood testing, you'll find some eosinophilia increase that is because eosinophilic, it affects eosinophilic tracking to issues. Most of the effects we had thought was a combination of IL-4 and IL-13 in this drug, and I noticed when I was looking at the PI this morning that at least in two of the situations they gave, that Dupixent has been labeled as an anti-IL-4 antibody, period. So it's a change from my thinking. I would have to ask the people today to help me with it, and we got some super people coming up. Dr. Gross is going to give us some detail on this, which is fine. I found easy to go over the top and skate. There's some problems with interleukin. There's some conjunctivitis. It's more common than you'd think. Some of the studies show up to 28% of people have it, but it may not be very significant. It may not be that you have to discontinue the drug, that you have to do anything, but it's a fairly common thing. The theories of causation for this is that you get a reduction in ocular cytokines that allows Demodex mites, you have to look for those carefully, causing an IL-17 mediated inflammation. You get the eosinophilia after dupilumab administration, and you get systemic IL-13 inhibition that indirectly leads to a reduction in goblet cells of the eye and other places, and sometimes it's almost like a rosacea-like syndrome. So you see bilateral conjunctivitis. Don't panic. Treat it the way you'd usually treat it. But you treat it like it does in allergic conjunctivitis. You'd rinse the eyes, you'd wet the agents, use ocular antihistamines. The problem is that you can't use antihistamines usually because antihistamines dry, or at least most of them do. So you may complicate things if you hit people hard with antihistamines. And if you have to get to the point where you use steroids, eye drops on people, which are commonly available, and none of us shy from that, you need to consult an ophthalmologist if a baseline is indicated. Okay, now this is a situation that's different though. This is, if you find somebody that just has one eye involved, and there's no sight problems, no drainage, doesn't hurt, who do you send them to? You send them to an ophthalmologist? Now, this is a situation that you call Sarah Connors. And those of you that didn't get that need some help. There are two medications on the boards for Dupixent, Aubrey and Dupixent. There's some things that we talked about yesterday in a meeting that you really need to know. You need to say that people have tried and failed other medications, including Montelukast. And their body surface area is over 10%. But hands, see, if you have hands involved, that's over 10%. So, you can still do hand eczema with this. You have to score it. And most of the time, the suggestion had been that you live it, that you have to have phototherapy a couple times a week for 6 weeks. Those of us in Phoenix and Texas just say, hey, we get plenty of phototherapy here, although that may not be true since we're all spending our time like moles underneath the ground here. if you're going to use some of the other things, well, Dr. Weibel talked about the JAK inhibitors. But Lori, is there anything we missed that we should have had from yesterday's discussion?
No.
Is that it? Okay. All right. All right. So here's a big, Dr. Lanier is a little dyslexic. So here's the big question that we're going to ask the panel. Would you choose to put a patient on an injectable drug that may be semi-permanent with a low potential for side effects, or an oral one with known sure side effects but can be stopped and monitored? This is the question that I'm going to be asking our little panel. And the other thing that we'll say is, when do you stop? So this panel will come up here in a second, and we'll get Dr. Storms, if he's available, and Dr. Weibel and Dr. Weldon to comment on. Because these are the things that get us. When do we stop? Okay.